Meredith, you just want to pop up for a minute? We'll just take about 5 minutes before we take the break with a couple of quick questions if people had. But if not, I have one which I think is to even think of for the panel, where we'll herd everybody up here and they can debate amongst themselves, and also questions from the audience. But a key theme that is present in Alberta. Oh, first of all, I might say thank you for the compliment on dealing with the pilots first. And I think people, as the deputy had said earlier, is to read the minister's speech that she had given at the Accelerating Primary Care Conference in December, but also the Alberta Medical Association Agreement, which is on the website. And I think it's a landmark agreement that is actually showing a lot of cooperation from the physician community in stepping up. And part of that is 5 blended capitation pilots, in which we actually had an advisory. I don't know if you were involved in it, but there was people from Ontario who were involved in advising, don't do some of our particular mistakes. And we had some international people as well saying this is how we need to structure the implementation of new funding models. But one quick question before the break for both of you, and maybe the panel members can think about it. We focused a lot on kind of the health delivery system, the acute care system. We focused on physician payment. 2 things I think to think about is integration in terms of the role of other providers, because I think that's seen as a bit of an issue of how do we incent towards medical to health homes and to interdisciplinary teams in terms of expanding that particular kind of shift, which is important. And what might be the role of local community governance as kind of delivering and planning services in a local region, because I think we've got a set of primary care networks which are trying to evolve, which came with a bit of money to groups of physician practices to plan services in the region, and a bit of additional money to help get other providers. But I know they're trying to do that with the local health integration networks, but that whole issue of how important local community governance is in planning services is to ongoing delivery of improvement of those wraparound services. We're pretty good at doing clinical pathways for diabetes or clinical pathways for this, but is there a kind of a local accountability organization that might be responsible for those full range of needs along a person's pathway? And that was just a kind of one thought. But how do we deal with first of all, before the break, just some comment on what about all the other providers who might support a particular patient?
Can I take the first question? Because there's no way I can address local governance. We don't have that. So I know nothing about how one might do that. Sounds intriguing. And something that Atul Gawande suggested years ago, having a sort of local quality improvement networks. But you know, in terms of thinking about how do you get to a more flexible notion about care delivery around teams and a whole range of professionals, I think what we have mostly tried to do is not to dictate what happens inside systems and how they deliver care, but if you think about using a global payment, either a capitation or a bundled payment, and not tying it to who does what in what way, then that provides space for that to happen. Of course, it's not automatically going to change, and so I think a set of tools as well is required. Unfortunately, so the way professional scope of practice is regulated in the U.S., it's state by state. And so in some states, some things are possible and not others. We looked at patient-centered medical homes across a whole variety of states, and some had these really incredible models where they empowered the sort of lowest level of licensure, medical assistants, mostly we call them, to do lots of important work, and it was incredibly rewarding, and those people would be willing to be paid less to do what was much better work for them. But in other places, it was just not possible, and so there's, you know, the ancient guild relationships that underpin those scope of practice laws, they're sort of hard to move.
Our experience in Ontario with interprofessional teams is that they're available to a quarter of the population, which is a great accomplishment, but what about the other 3/4? You know, if your neighbor where you live has access to a social worker for counseling, a pharmacist to review their medications and maybe help them with smoking cessation, an income support worker, and a lawyer, as Andreas alluded to this morning. And a nurse practitioner who's going to make home visits and track people as they leave hospital. Your neighbor has all that, and you don't, because you happen to see a different doctor, or you happen to go to a different clinic or a different provider, and one of those doctors decided to join a group that has all this and the other didn't, and you have the same healthcare needs. This kind of flies in the face of Canadian values, of what we believe in terms of provision of care according to need. And for that reason, Ontario has kind of said this access to interprofessional teams is highly inequitable by urban and rural and across need, and has actually designed and now passed a law, a somewhat controversial one if you talk to the Medical Association, about setting up sub-regions. So our local health authorities are called local health integration networks, and inside those, each now is going to have anywhere from 4 to 6 sub-regions that will plan and organize services locally with major, their major marching orders are around attachment. Even though we're at a high level, people are often not really attached, even though they say they are. So around attachment to primary care, and also around delivering interprofessional care to the people who need it the most. So that's going to be done locally, although some places have already got a lot of interprofessional team resource and others have none. So how they're actually going to share and spread that across, and how it's all going to be, I don't think there's local governance that's talked about just yet. The governance is still more at the health authority level, but over time it could devolve to those lower levels. But the idea will be to take a much more needs-based approach to interprofessional teams. How that's actually going to happen, and how it's going to happen in our current environment of cost constraints, I don't know.
Yeah, and I'm going to let you have the first question right after the break, Blair, if that's okay. And that, because I just wanted to move quick. Oh, that's the kind of thing. But I think, as Murray Ross has said to me a bunch of times, there's only so much you can do about actually dealing with integration across services until you actually integrate the organizations itself, and so that kind of might be at the margin. But 15 minutes, and we'll be back for be able to have a discussion with all the panelists. Thanks very much.